In this episode of Let's Go Shorts, we will learn about the classification and evaluation of the disease of obesity. I am Dr. Peter Ammon, a medical bariatrician who works in Portland, Maine, with Maine Health. Body mass index, or BMI, is a person's weight in kilograms divided by the square of the height in meters. It moderately correlates with direct measurements of body fat and is a simple, non-invasive way to screen for a patient's risk for health problems related to their weight. It is not a perfect measurement. For example, if someone has more muscle than fat, BMI might measure high but not indicate risk for health problems. Also, in different racial and ethnic populations, BMI ranges may differ with regard to disease risk. BMI is used to classify weight categories as per this chart. Underweight is a BMI less than 18.5, normal category is up to 25. Overweight is defined as a BMI of 25 to 30. Then class 1, 2, and 3 obesity categories correspond to 5 BMI point ranges above 30. Class 3 obesity used to be called morbid obesity. While BMI is not an exact measurement of health, people who have obesity have an increased risk for many diseases and health conditions, including all causes of death, high blood pressure, high cholesterol, heart disease, stroke, and certain cancers. Generally, the higher the BMI, the higher the risk. Depending on the severity of obesity, interventions to help improve this disease process starts with lifestyle interventions for anyone above a BMI of 25. Traditionally, if a patient has a BMI above 27 and other medical problems, weight loss medications can be considered. If patients have a BMI above 30, but no other medical problems, medications can be considered. Patients with class 2 obesity, above a BMI of 35, can be offered weight loss surgery if they have other medical conditions, since these patients already are sick or at risk for complications of their health. And if patients have a BMI above 40, even with no other comorbid conditions, surgery can be offered. However, just recently in October 2022, the American Society for Metabolic and Bariatric Surgery guidelines were updated for the first time in 30 years. New guidelines recommend metabolic and bariatric surgery for individuals with a BMI of 35 or more, regardless of the presence, absence, or severity of obesity-related conditions, and that it be considered for people with a BMI of 30 to 35 and metabolic disease, and in appropriately selected children and adolescents. Even without metabolic disease, the guidelines say weight loss surgery should be considered starting at a BMI of 30 for people who did not achieve substantial or durable weight loss or obesity disease-related improvement using non-surgical methods. It was also recommended that obesity definitions using standard BMI threshold be adjusted by population, and that Asian individuals consider weight loss surgery beginning at a BMI of 27.5. One approach to working with patients to address the disease of obesity is the 5 A's approach developed by Obesity Canada. This uses motivational interviewing techniques to start the conversation with the patient and guide the discussion with theory-driven, evidence-based interventions that can be accomplished in several minutes. This approach lets the patient be in charge of the conversation and development of a realistic treatment plan. Weight can be a very sensitive issue for patients, and as we learned in previous shorts, can be embarrassing, and patients may fear blame and stigma. Asking permission to talk about their weight allows a patient control over their health and what they may feel ready to address today. If they do not feel ready to talk about their weight, the provider should respect that wish and offer to perhaps talk about it at a different time. Assessment includes not only measurements of height, weight, perhaps waist circumference, but should include a thorough history of previous weight gain and loss. Reviewing the weight curve in the EMR may be helpful. Taking a brief diet history and activity history can highlight areas the patient may want to address. Discussing family history of diabetes, heart disease, and obesity can highlight a patient's risks, and reviewing medications and medical conditions that can affect weight is important. Advising the patient about potential health risks that can accompany their weight can be helpful. Discussing benefits of weight loss with regard to improved ability to enjoy life, have the energy to do more things, live longer and healthier, and maybe even stop some medications may be motivating for patients. Discussing an initial weight goal of 5 to 10% of their initial weight can help set more realistic expectations. So for a person who weighs 250 pounds, a goal of 12 to 25 pounds initially might be reasonable. Often quick fixes or fad diets that patients may see online are not sustainable or backed by evidence, and many do not provide long-term weight loss. Also, discussing that obesity is a chronic disease and that interventions over the long haul are necessary to sustain any gains is important. Advising the patient that even if weight loss medicines or surgery are chosen, lifestyle management is so very important to be able to sustain any weight loss over time. agreeing to realistic goals with the patient is necessary, and patients may only be able to focus on one small step or change at a time to improve their health. Being able to measure something, how much water they drink, steps, calorie intake, minutes of exercise per week, or weight can be helpful. The last A is assist the patient to help them address barriers to success, which could be handouts, websites, referral to formal programs, mental health support, dietitian referrals, athletic trainers, or physical therapists or other weight loss programs can be helpful. Also, agreeing on how and when to set a short-term follow-up can be helpful, provide accountability, and reinforce behavior change for patients. This could be an email, phone call, staff check-in, text, telehealth, or an in-person follow-up. The good news is that sustained weight loss of even 3 to 5% of someone's weight is likely to result in clinically meaningful reduction in cholesterol, blood sugar, and the risk for developing type 2 diabetes. Greater amount of weight loss will reduce blood pressure, improve cholesterol further, and may even reduce the need to take certain medications. This work is not easy, but can be rewarding for both the provider and the patient to know they are making changes to improve their health one small step at a time. What do you think about these Let's Go shorts? Are they helpful for your practice? Entertaining? Too long or too short? We would love to get some feedback, so if you're interested, please contact Dr. Tori Rogers at the email above to give your thoughts. We are offering a $25 Amazon gift card to those who complete a short interview with Dr. Rogers. Thank you.